As a clinician, you are constantly tasked with measuring the unmeasurable. You can easily track blood pressure, right? You can check a pulse, but how on earth do you actually quantify human suffering? Well, today we are mastering the ultimate clinical tool designed to do exactly that, the visual analog scale, or the VAS. In this explainer, we're going to explore how this brilliantly simple tool transforms a patient's entirely subjective feeling of pain into hard, objective, and most importantly, actionable clinical data.
Here's the roadmap for this explainer. First, pain, the fifth vital sign. Second, VAS methodology and administration. Third, clinical interpretation of results. Fourth, VAS advantages and alternative types. And finally, dynamics and clinical case.
Okay, let's dive into section 1, pain, the fifth vital sign. So, in modern clinical medicine, you've got your pulse, your respiratory rate, blood pressure, and body temperature. Those are your 4 primary vital signs. But recently, the medical community officially recognized pain as the 5th vital sign. Now, the core clinical dilemma here is glaringly obvious. We have tonometers to precisely measure blood pressure, and we have thermometers for temperature, but there is absolutely no painometer that you can just plug into a patient. You can't just draw blood to see how much a broken leg hurts. So, how do we actually measure it? Well, this brings us to our solution, the visual analog scale. The VAS is a psychometric tool. It is literally just a perfectly straight 100 mm horizontal line. The left end represents absolute 0, no pain whatsoever. The right end represents 100, the worst imaginable pain. The patient simply places a mark somewhere on that line. What's so brilliant about this is that the VAS serves as the crucial mathematical bridge. It connects the patient's completely subjective internal feeling directly to the doctor's absolute need for objective, recorded data. Moving right along to section 2, VAS methodology and administration. I am speaking to you directly as a mentor right now, because incorrect instructions lead straight to incorrect diagnoses. First, you present the classic 100 mm line. But notice this absolutely strict psychological rule. No numbers can be visible to the patient. Why? Because patients will instantly mentally anchor to a favorite number or maybe a perceived passing grade. You don't want them doing math in their heads. You want them expressing a feeling. Second, you give crystal clear instructions. You say, the start is no pain, the end is the worst imaginable pain. Third, you ask the patient to make a single vertical mark representing their current state. And finally, after they hand the paper back, you, the doctor, physically measure the distance from the start line using a ruler. The math behind this is honestly beautifully simple. The formula for the VAS score is literally just the physical distance from the start to the patient's mark in millimeters. For example, if you lay down your ruler and the distance is 45 millimeters, boom, the score is 45. If your hospital uses a 1 to 10 scale instead, you just divide by 10, giving you a 4.5. It is really that direct. So, the crucial point is, how do we use this? Let's get into section 3, clinical interpretation of results. I highly urge everyone viewing this explainer to commit these exact millimeter brackets to memory. This is your ultimate cheat sheet for pain severity. 0 to 4 millimeters means no pain. The patient is comfortable. 5 to 44 millimeters is mild pain. It's noticeable, sure, but the patient can still go about their day. 45 to 74 millimeters is moderate pain. This is where quality of life really drops, and the pain demands their attention. And finally, 75 to 100 millimeters is severe, unbearable pain. In this zone, movement is totally restricted, the patient might be crying, or they might even be going into clinical shock. Now, there is one specific number I want to aggressively highlight here, 33 millimeters. Clinically speaking, 33 millimeters is the magic threshold. When a patient's VAS score crosses that 33 millimeter mark, prescribing pain-relieving analgesics becomes clinically mandatory. You simply cannot ignore a score of 34. Having this precise threshold takes all the guesswork out of when you need to medicate. Let's shift gears and look at section 4, VAS advantages and alternative types. The advantages of the VAS are incredibly clear. It has sky-high sensitivity, meaning you can track tiny millimeter-level changes in a patient's recovery that words alone just can't capture. It's also universal, cutting straight through language barriers, and it requires zero expensive lab equipment. But, no tool is perfect. The idea of placing physical pain onto a geometric line, that is a very abstract concept, especially for some elderly patients. Plus, it actually requires the fine motor skills to hold a pen and draw a mark, and it demands complete cognitive awareness from the patient. Because of those limitations, we have 3 main alternatives that you'll frequently use in the hospital environment. First is the numeric rating scale, or NRS. This is your classic verbal 0 to 10 question. It requires no paper, making it perfect for fast-paced emergencies. Second is the Wong-Baker Faces Scale, which uses 6 emotional faces. This is absolutely essential in pediatrics or for patients with cognitive impairments like dementia who just cannot process abstract numbers. And finally, the Graphic Rating Scale, or GRS. This is essentially the VAS, but with words like mild or severe printed along the line. It helps orient the patient, but keep in mind it does slightly lower that strict mathematical precision. Let's move on and see how this builds in the real world. Section 5. Dynamics and clinical case.
Before we see our patient, you need to understand one more vital number: 13 millimeters. This is the minimum clinically important difference, or MCID. The greatest power of VAS is tracking dynamic changes over time. Statistical research shows that for a patient to actually feel a meaningful improvement in their body, their score must drop by at least 13 millimeters. If you administer a drug and the score only drops by a mere 5 millimeters, well, that chosen analgesic has clinically failed, and you need to pivot your strategy immediately.
Okay, let's set the high-stakes scene for our patient. Imagine you are on the surgical ward. Your patient is exactly 4 hours post-operation for acute appendicitis. They are tossing, turning, sweating, and telling you they feel absolutely terrible. This isn't just an academic exercise about drawing lines on paper anymore. This is about providing actual, urgent human relief. So you hand them the blank VAS line.
The patient makes their mark, you whip out your ruler, and you measure it. The result is shockingly high: 82 millimeters. Based on our chart from earlier, this places the patient firmly in the severe, restricted movement pain zone.
Because that score is well above our 33 millimeter action threshold. And honestly, deep into the severe zone, you take immediate clinical action. A narcotic analgesic or a strong combination therapy is prescribed and administered to the patient right away. You wait exactly 1 hour to let the medication take full effect, and you retest the patient with a fresh, blank VAS line. You measure the new mark, 25 millimeters, and this brilliantly illustrates the true power of the VAS. The score dropped by 57 millimeters. That is way past our 13 millimeter minimum requirement. You now have objective, undeniable mathematical proof that your patient has successfully shifted from severe suffering right down into manageable, mild pain. We're going to wrap up this explainer with a pretty provocative thought. The patient's stated pain is their reality, and VAS is the bridge to acknowledge it. You know, as medical professionals, it is incredibly easy to get lost in lab results and imaging, but pain, while totally invisible on an X-ray, is a completely real crisis for the human being lying in the bed in front of you. The visual analog scale is so much more than just a ruler and a line. It is your ultimate clinical tool to validate, measure, and effectively treat the invisible suffering of your patients. Will you take their reality seriously the next time you walk onto the ward? Think about that. Thank you so much for joining me for this explainer. Keep learning, and I'll see you next time.